Good evening, my name is Dr. Kyle Solano and I will discuss to you tonight bone marrow failure. No? Bone marrow failure is a condition in which the bone marrow fails to produce the adequate amount of your peripheral blood cells. Example, your RBCs leading to anemia, your platelets leading to increased bruising and easy bleeding, and your WBCs leading to increased susceptibility to infections. No? So it's mainly represented by pancytopenia, no? Meaning a decrease in all um, blood blood cells. No? So pan meaning all, cyto meaning cells, penia meaning decreased. It can be caused by a variety of causes. Example, infections, viral infections, chemicals or drugs, and autoimmune conditions. No, it may also be caused by your vitamin B12 and folate deficiency, leading to a poor maturation of your cells, and it can also be caused by premature senescence and apoptosis of your cells, which means the cells are easier to die. No, they are more sensitive to apoptosis, disruption of bone marrow environment, which can be caused by trauma, kana, and decreased bone growth factors like your CSF, colony stimulating factor GM, loss of hematopoietic cells due to invasion of your tumor, such as in metastatic cancers, and like in TB, wherein fibrosis and granulomatous inflammation replace the bone marrow hematopoietic cells. No? So the symptoms, like I said earlier, are easy bleeding and bruisability due to decreased in platelets, susceptibility to infections, fatigue due to the low hemoglobin count, no, due to low RBCs. So aplastic anemia, aplasia meaning synthesis, creation, in or growth. You just put an "a" there to indicate absence. So aplastic meaning no creation, anemia, no. So the features are pancytopenia, meaning, like I said earlier, decrease in all bloodlines, no? Reticulocytopenia, decreased immature red blood cells in the peripheral blood. Reticulocytes represent the bone marrow erythropoiesis, no? They can be an index for erythropoiesis. So if there is decreased reticulocytes, meaning the bone marrow fails to produce more red blood cells in response to the need, in response to hypoxia. No? So bone marrow hypocellularity, meaning that the hematopoietic cells in the bone marrow are being replaced by fibrous tissue or by adipose tissue. Decreased hematopoietic cells, meaning that the hematopoietic cells are decreased either by chemical, direct damage by chemicals, drugs, and or by autoimmune mechanisms. No? So acquired aplastic anemia is the most common, 80 to 85%. No, maybe the most common is idiopathic. Nobody knows the reason. So or secondary may be caused by a primary condition. So acquired aplastic anemia happens after birth. You acquire it as you grow up, no, as you live in this world, no. And then the secondary means you have cancer first and then you develop aplastic anemia, or you took a chemical first and then you had aplastic anemia. One example for this secondary acquired secondary aplastic anemia is your parvo B19 infection, no? In which you get infected by parvo B19 as a child, and then the virus kills your erythropoietic cells, leading to a decrease in RBCs. So the primary condition in this is the parvo B19 infection, leading to a secondary aplastic anemia of the red blood cells. No, once your body kills the parvo B19 virus, the secondary aplastic anemia then resolves. No, so simply put, if you take away the primary condition in secondary aplastic anemia, the aplastic anemia will also resolve. This is what I said earlier, no? So the higher the dosage of the viral load of the parvo B19, or the higher dosage of the medication or the chemical taken, the more severe the aplastic anemia will be. The lower the hemoglobin, the lower the WBC count, the greater the thrombocytopenia, no? So the withdrawal of the offending agent will lead to recovery. So this is a list of the ones that can cause aplastic anemia, infections, and there's drugs, no? So this is what I said to you earlier: parvovirus infection, fifth disease, no? Aplastic crisis, no? So the pathophysiology of aplastic anemia is both quantitative and qualitative, meaning there is a decrease in the overall population, and there is a production of abnormal blood cells leading to EC death or EC apoptosis or premature senescence, no? This is a peripheral blood film of a patient with aplastic anemia. So actually this film is not representative of aplastic anemia in general. Now you need to have a series of fields to see prior to diagnose aplastic anemia, and you also need to have a bone marrow biopsy, no? That's why you really need to follow your four characteristics ganina, like your pancytopenia, bone marrow hypocellularity, your decrease in hematopoietic cells, and your reticulocytopenia. So you really need to follow those guidelines when you're looking in these fields, no? And you also need to have your bone marrow biopsy, no? So the laboratory findings for your aplastic anemia, no? You can see pancytopenia, anemia, usually 10 milligrams per DL ang hemoglobin, increased MCV, like in megaloblastic anemia. So when we have macroovalocytes or megaloblastic like mga RBC, no, that means they have poor maturation, no? Meaning they were they don't have optimum maturation, in a sense that they didn't take out their mitotic spindle pad, they didn't put out the proteins that needed to be put out of the cell pad. That's why they have this unnecessary stuff inside their cytoplasm, making them big, no? And then apart from that, their hemoglobin isn't as packed as efficiently as it should, no? So leading them to have this very big spherical shape. So this spherical shape will of course increase your MCV, no, your volume of the RBC, but this will also make your RBC quite susceptible to lysis, especially when it comes to the spleen, that the RBC needs to be distensible. That's the purpose of your biconcave disc in your RBC, no? So it can be distensible through the crevices of your spleen. If it's just a big indispensable blob sphere, then it can easily pop, no, within the crevices if it's pushed through. So reticulocytopenia, like I said earlier, it is a reflection of decreased RBC production of the bone marrow, leukocytopenia, and increased liver function tests, no? So this happens because when your bone marrow is failing, like in aplastic anemia, no, it's not producing as much RBC as needed, no? So your other organs try to compensate, like your liver and spleen. They try to do extramedullary hematopoiesis, no? So what happens is, due to the extramedullary hematopoiesis in your liver, this leads to irritation or damage to the surrounding hepatocytes, leading to an increase in your liver function tests, no? This is all due to compensation, no? So this is a slide where on the top, please refer to your Quipper if it's too small, no? Notes on your Quipper, please refer to it. The top slide, we can see that the bone marrow is quite cellular, and on the bottom it's quite filled with adipose tissue, no? So in the bone marrow, when you're still young, no, when there's still adamant hematopoiesis, no, it's normal to have this kind of bone marrow. It's filled with hematopoietic cells, no, inside. This one here is hematopoietic cells. In contrast to an adult bone marrow, in which you don't need as plenty, as much as when you were younger hematopoiesis, the bone marrow atrophies and the hematopoietic cells are being replaced by adipocytes, no? But in aplastic anemia, some conditions can accelerate the atrophy or the replacement of the extramedullary, either medullary cells or the hematopoietic cells with um, adipose tissue, leading to like aplastic anemia, no? So presence of paroxysmal nocturnal hemolysis cells, meaning like I said earlier, aplastic anemia is not only quantitative um, anemia but also a qualitative, meaning there are many qualitative, meaning morphological, functional, physiological defects in the RBC membrane, no? Paroxysmal nocturnal hemoglobinuria occurs when your RBC membrane doesn't produce a protective factor against your complement, no? Complement is always present in our blood, and all the cells within the bloodstream, including our blood cells, are protected against the complement because of some like protective proteins, no? So, di ba non-specific man ang complement? So, unless they are attached to an antibody, they are non-specific in the most part. So, when this protective protein in the RBC gets lost due to ineffective hematopoiesis or ineffective maturation, complements then attach to the RBCs, thus lysing, thus hemolysis occurs. Kaya of course, ma-activate man ang membrane attack complex, no? So this occurs in a setting of acidic na plasma, no? And acidic plasma usually, well, more acidic plasma occurs when you are sleeping, when you have a lower respiratory rate, thus you retain more of the carbon dioxide and you don't blow it dayon, no? So that's why acidic gamay imuhang plasma. So this acidic plasma then activates the complement in your blood cell, in your plasma, activating your complement, and subsequently the complement will attach to your RBCs, thus lysing it at night when you are sleeping, no? So prominence of fat cells in the bone marrow biopsy, like I showed to you earlier. So the management is of course blood product replacement. Kung mubo kag hemoglobin, of course we're gonna give you pack RBCs, no? Mubo kag platelet, of course we don't give you platelet dayon. We need to see if it's kanang grabe na jud kayo. So blood product replacement is very good for, of course, emergencies jud, no? But it shouldn't be done on the regular because you might get sensitized and produce antibodies, which will eventually lead to transfusion reaction somewhere down the road when you get transfused again, no? So immunosuppressant therapy, this is effective in autoimmune cases of aplastic anemia, and the gold standard for management for now of aplastic anemia is bone marrow transplantation, no? In which your faulty hematopoietic cells are replaced by healthy and functioning hematopoietic cells in the bone marrow. So congenital bone marrow failures, no? So if you think about it, congenital bone, if acquired, meaning it happens after you get born, no? Congenital bone marrow failure syndromes occur even before you were born, no? It's an ongoing process that starts upon your conception, on your conception or after a few weeks siguro during your you're in your mother's uterus, no? So So this is basta congenital, you were born with it, no? So the most common are Fanconi anemia, dyskeratosis congenita, and Schwachman-Bodian-Diamond syndrome, no? So these syndromes are usually accompanied by multi-organs. So not just it's not just na sila pancytopenia, naapod sila kanang mga skin pigmentation, short stature, no? So kato. So Fanconi anemia, skeletal malformations, skin pigmentations, short stature, and abnormalities sa eyes, kidneys, and genitals. No, so there are deletions sa genes, no, and the most are autosomal recessive, except Fanconi B, which is X-linked. So please read these notes, no. So most common is deletion is Fanc A, and second is Fanc C with the poorest prognosis, no. This is a child with Fanconi syndrome, so the child has short stature, no. Tapos hyperpigmentation in the bottom left, and then sa iyahang chest, no. Tapos to. So the laboratory findings are similar to your aplastic anemia no, na acquired. Tapos kato, diagnostic test is chromosomal breakage analysis, because like what was stated earlier, no, most of the congenital aplastic bone marrow failure syndromes are multi-organ, no? So sometimes they overlap from one another. So the best way to diagnose is really to check the genetic structure, no, to make sure that this child has Fanconi anemia. So like I said earlier, the only curative treatment for Fanconi anemia and other aplastic anemias kanang mga chronic is kanang bone marrow stem cell transplant, no, stem cell transplant of the bone marrow, no, so bone marrow transplant. Dyskeratosis congenita, it's a rare syndrome, no, so it's an X-linked gene mutation for the gene encoding dyskerin, same laboratory findings as Fanconi anemia. So the triad, don't forget this triad, is skin pigmentation, dystrophic nails, and oral leukoplakia. It's hard to find pictures of this good. So kato. So remember, dyskerin for dyskeratosis congenita, Fanc A and DCK1 gene. Tapos ang protein na iyang gina-encode is dyskerin for dyskeratosis congenita. Fanconi's anemia, ang gene deletion is most common in Fanc A. Fanc B is the only X-linked, all are autosomal recessive. Fanc C is the second most common and has the poorest prognosis, meaning worse outcome pag prognosis, no. Tapos ang next nato is Schwachman-Bodian-Diamond syndrome. So it's the same symptoms and laboratory finding as your Fanconi anemia and your acquired aplastic anemia syndrome, plus pancreatic insufficiency, no? Meaning kung pancreatic insufficiency, mataas imong amylase, lipase, no? Kato. Mo increase pud imuhang hemoglobin F, no? Your hemoglobin F, like I said earlier, no? When you have anemia and aplastic anemia and your bone marrow isn't producing as much hemoglobin as much red blood cells as it needs to, your other organs will compensate for that using extramedullary hematopoiesis, no. And then the RBCs they produce aren't as efficient, no. So these RBCs they produce, especially in the liver, have fetal hemoglobin F, no. So which is as efficient as carrying oxygen to the tissues as your adult hemoglobin, no. So mao na mo taas imong hemoglobin F due to the extramedullary hematopoiesis, no. So ito, Pure red cell aplasia, no? Ay, one thing to note ay, if mag-decrease ay mag-increase po imong pancreatic enzymes, no? If they're increased in the blood, um, what happens is dili na sila maabot sa imuhang GI tract, no, in which they are needed. Always remember that lipase is needed for fat digestion. If nitaas siya in your plasma, meaning wala na siya nitaas sa imuhang tinae, wala na the GI tract doesn't have an adequate amount of lipase, no, leading to poor fat digestion. So kato. So poor fat digestion, poor fat absorption, leading to steatorrhea, meaning fat imuhang poops, no. Pure red cell aplasia. So kung pure red cell aplasia, meaning the only affected cell line is your erythrocytes, no. Pure red cell lang man siya, no. So primary or secondary, like I talked about earlier, no, acquired pure red cell aplasia is caused by your parvovirus B19, no. It's a type of acquired aplastic anemia, but specifically it's an acquired pure red cell aplasia, no. So it only targets your red blood cells, no. It's a childhood disease, fifth disease, no. So it has normal levels of hemoglobin F, meaning there is no extramedullary hematopoiesis because it is just a transient, no, na infection. Mawala lang siya in time, unlike kung chronic siya, longer time in which your body really needs to compensate the anemia. So kato, there is no need for extramedullary hematopoiesis, no. So your congenital pure red cell aplasia is your diamond black fan. So kato, severe macrocytic anemia with reticulocytopenia. Like going back, reticulocytopenia is like an indicator for poor RBC production, no. So normal imong platelets and imong WBC. Increased imong hemoglobin, fetal hemoglobin, kaya na naka-extramedullary hematopoiesis, no. So congenital PRCA, kani congenital dyserythropoietic anemia. So kato CDA1 may mga neurologic defects, no. Tapos in comparison to your diamond black fan, no, diamond black fan, you have really a decrease in your erythropoietic cells, but in your congenital dyserythropoietic, meaning sufficient amount of erythropoietic cells, but they produce mature RBCs is quite defective. That's why dyserythropoietic siya, no. So iyahang mga RBCs na ma-produce is immature, dili kaayo efficient, prone to early apoptosis and dying. So more or less aplasia gyapon siya, aplastic gyapon siya yung mahulog, no. So kani Swiss cheese appearance ang ihang mga erythroblast, that's characteristic of it. And ang CD2 is positive for is also known as your HEMPAS, no. So hereditary erythroblastosis multinuclearity with positive acidified serum, no. It's like your PNH ganiha. So mag-hemolyze siya tungod sa complement, no. HEMPAS, that's your Swiss cheese appearance of your erythroblasts, no. So since they're still blasts, they're still immature, that's why they have a nucleus pa, no. Pag blast pa, immature pa, no, compared to your erythrocyte. So look over here, Swiss cheese siya kay iyahang chromatin. There are clumps of chromatin here, and this is the clumps, this is your heterochromatin, the clumps together, and the lighter staining one is your euchromatin, no. So myeltic anemia, this is an infiltration of the bone marrow of abnormal cells like your metastatic tumor cells and inflammatory cells, no, from your miliary TB and your fungal infection. Simply put, they just replace the space in the bone marrow with kato abnormal cells, and when the abnormal cells are there, they disrupt the bone marrow environment, leading to a very non-conducive, no, it's a non-conducive environment for erythropoiesis, or yeah, erythropoiesis or hematopoiesis, no, in general. So kato dili mag-grow pod kayo ang mga blood cells nimo dito, tapos magka-anemia ka, murag usa ka siya caustic environment, no. And anemia of chronic kidney disease is due to decreased erythropoietin produced by your defective kidney. It's just simply as that. And your anemia of pregnancy is a dilutionary anemia, no? Because when you're pregnant in females, you tend to hoard lots of fluids, leading to a dilution in your RBCs in the blood. Thus, when makuhaan kag dugo, it's mistaken to have anemia. Kato dahil ni daghan na dahil mohang plasma, no? But it's a response to pregnancy because you're expected to lose blood in pregnancy, no? So instead of losing your RBCs, you lose the fluid, no, when you bleed, no? So dili kayo affected imong RBC population, katulang fluid ang na-lose, no, to maintain your blood pressure for perfusion. So that's it. Thank you. So if you have any questions, no, if you have any questions, please don't be shy to hit me up in Messenger or sa ba PM ba ko ninyo or anything. Or you can also just PM your class representatives to talk to me para makumpile lang pud nila ang concerns, no. I'll take the questions in my quiz. I will all take from the handouts and some in the book, no. So I advise you to really read and digest my handouts. I'm sorry if I'm not very adept at using this video format or for lectures, no. So it's quite new to me. So please bear with me. I ask for understanding. And kato, if you have concerns, please address to me. I believe I'm one of the easier easier lecturers, no. But I also expect you to study hard pod. So, thank you for your time. God bless you. So, don't be shy to talk to me. Sorry if my lenses are reflecting the screen. I need my glasses. So, thank you. Goodbye. God bless.